Okay, welcome back to the Auditory Learner. This is going to be, I believe, the first video for Cariology and Occlusion, DH400. And this is going to be the study video number one for the first midterm, which is going to include occlusal biology, occlusal trauma, TMD screening, TMJ disorders, and dentinal hypersensitivity. I believe we can do this all in one go. Partly because I have already created a script as a study guide. Um, and let's get into it. So, for occlusal biology, we need to know that occlusal trauma does affect the PDLs, the bones, and the roots. Occlusal trauma, with the addition of biofilm, will cause bone loss. Dental hygienists must recognize the signs and symptoms of pain and dysfunction. So, we have what's called traumatic occlusion. Okay, traumatic occlusion is when there are occlusal forces that exceed the adaptive capacity of the tissues, and it results in injury. Also, remember that clast, destroy, and blast build. Okay. Official definition of occlusal trauma. Okay. It is injury to periodontium when occlusal forces exceed adaptive capacity of the tissues. It could be acute, it could be chronic, primary, secondary, or a combination of both. So we kind of I just mentioned that only in a different way. I said traumatic occlusion. Now we're talking about occlusal trauma. Same thing. It is the injury to the periodontium when their occlusal forces exceed adaptive capacities, and the tissue, and it affects the tissues. So, acute occlusal trauma is abrupt, painful, mobility, sensitive to percussion, must correct right away for this. Chronic occlusal trauma is more common. It's gradual. It's wearing away of teeth, the drifting, and combined with parafunctional habits, which could be such as nail biting, thumb sucking, as well. And I believe that would be also be bruxism. So one thing we need to know is that malocclusion, people who have malocclusion, it's not because of trauma. All right. We need to also know the difference between morphofunction and orthofunction. Morphofunction is when the teeth and the neuromuscular system are in harmony within adaptive physiological range. That's morphofunction, morphological function. Orthofunction is physiologic occlusion, and it functions well even within malocclusion. It is adaptive, which is considered to be orthofunctioning. Functions well even with malocclusion. All right, so malocclusion could be still an orthofunction. Okay. Dysfunction is when the function and parafunction exceed what the individual can handle. So parafunctional activities, parafunctional habits are things like bruxism, excessive masticatory loads, several hours a day. So I just mentioned that before. There are 5 muscles for mastication. You have 3 elevators, which is the masseter, the medial internal pterygoid, and the temporalis. So the 3 elevators of the 5 muscles of mastication are masseter, which assists with protrusion and placing the condyle against the articular eminence. You have the medial internal pterygoid, which is another elevator used for mastication, and the temporalis, which helps retrude the mandible. All right, then you got the 2 depressors, which are your lateral pterygoid and your digastric. So 3 elevators, 2 depressors. Then we have angles classification as far as bite. Okay, so class 1 is orthognathic, it's straight. Class 2 is maxillary prognathism, so meaning that the maxillary teeth kind of come out further than usual, and the mandibular is in retro. So that's also called convex or class 2. So again, class 1 is straight, orthognathic. But class 2 is when it's maxillary prognathic, and the mandibular is back, or it may appear to be further back. And then class 3 is maxillary retrognathum, concave. Weird. I would say that's when it sticks out. Class 3 is when you have a huge underbite. Class 2 is when you have a huge overbite. Let's double, triple, double. Yes, sir. Okay, so class 2 is mainly a big overbite. Yeah. Class 2 is a big overbite, but also the mesial buccal cusp or the maxillary first roots, maxillary first molar does occlude it's like straight on top of the mandibular first. Again, okay, so just look at it like this. Class 1 is correct. Class 2 is big overbite. Class 3 is big underbite. All right. Now we need to understand the difference between centric relation and centric occlusion. Centric relation is the relation of the mandible and maxilla when the condyles are in their most posterior and superior positions in the mandibular fossa. Centric occlusion is when the occlusal surfaces provide maximum contact or intercuspation. All intercuspal, also called intercuspal position, it's literally 138 occlusal contact points in the 32 permanent teeth, and this is very rare. So you have centric occlusion when the condyle is in the most posterior superior. Centric relation is when the condyle is in the most posterior superior position in the mandibular fossa. Then you have centric occlusion, which is the occlusal surfaces maximum contact happening, okay? And it would be 138 contacts for 32 permanent teeth, and that's rare. There is usually a 1 millimeter shift for centric occlusion. So here's the thing. There's a 1 millimeter shift if you are in centric relation to centric occlusion. There you go. That makes sense. So when your condyle and your mandible is all the way in the posterior superior position in the mandibular fossa, that is when if you move to centric occlusion, there'll be a 1 millimeter shift. There we go. All right, now let's talk about occlusal trauma. We have the whole lecture on that as well. And what we need to know about occlusal trauma is that PMD is a grouping of musculoskeletal conditions with the addition of pain or dysfunction of the masticatory system. That's temporomandibular joint disorders. That's a group of musculoskeletal conditions with the addition of pain or dysfunction of the masticatory system. Then we have extracapsular is muscles, so it's outside of the capsule. Intracapsular is the joint. Extra outside of the joint, intra is the joint itself. Periodontal response, if more than normal, then it causes injuries. If it's less than normal, it causes atrophy. And how do we want to say that? So any tissue needs stimulation to maintain its health. So any tissues, that's right. So if you want to maintain things clean and you want to have good health and good behavior, this goes with everything else, not just your teeth, then you need to stimulate it, but not above normal. So any tissue that needs stimulation to maintain its health. If you stimulate it more than normal, then it can cause injury. If you stimulate it less than normal, then it can cause atrophy. And we're talking about periodontal response to external forces. So the periodontium also needs stimulation within the physiological limit. Okay. Traumatic occlusal relationships are occlusal disharmony, functional imbalance, and occlusal dystrophy. Traumatic occlusal relationships are referred to as occlusal disharmony, functional imbalance, and occlusal dystrophy. Trauma from occlusion increases bone loss and pocket formation in the presence of biofilm, which we mentioned earlier, especially because that exceeds the adaptive capacity. These terms refer to the occlusion that the periodontium, not to the position of the teeth. The occlusion that affects the periodontium and not position of the teeth. Okay. So again, occlusal trauma is not malocclusion, and occlusal forces are not traumatic if the periodontium can't accommodate for it. So we need to understand what the difference between primary occlusal trauma and secondary occlusal trauma. Primary occlusal trauma is the alteration of the periodontium solely by occlusion. So the normal periodontium, but heavy forces. So healthy gums, but a lot of bruxism. Then you have secondary occlusal trauma, which is already affected by perio disease with excessive forces, not initiated by trauma from occlusion. And that's kind of like just what we just said. So the presence of inflammation and disease will increase the attachment loss if the trauma continues. We know that lateral forces are horizontal. We know that protrusive and retrusive forces are forward and back, not side to side. Torque is rotation. Both are likely to injure periodontium. Also understand the 3 stages of injury. Stage 1 of injury. Stage 1 is the worst stage because it's the injury stage. It's increased occlusal forces and the body tries the best to repair things if things stop. If it's chronic, periodontium will remodel. Stage 2 is repair. That increases resorption and bone loss, constantly occurs with healthy tissues. So we're always in a state of repair. Stage 3 is adaptive remodeling. When the repair process cannot keep pace with the destruction by the occlusion, periodontium will remodel. And this results in thick PDLs with funnels shaped at the crest, angular defects in the bone, loose teeth, and increased vascularization. So stage 3 is bad. I think, you don't want to even think about these 3 stages. You want to stay, if anything, at repairing and just maintaining, which is technically stage 2 because stage 2 is repair. It's increased constantly occurs. But so what we're talking about here is if you're in just constantly grinding your teeth, okay, just constantly do it. It's like the first time you start doing this, it becomes injurious, right? The body tries its best to but then stage 2 is like, all right, now the increased resorption and bone loss constantly occurs with healthy tissues. But then stage 3 is adaptive remodeling. It is now when it's thick funnel, angular defects that you can loosen your teeth and we can have increased vascularization. So again, we're just going to go and review all this again. We have primary trauma, which is trauma from occlusion that occurs with the alteration in the periodontium. It's caused solely by occlusion. Okay, and then secondary trauma. It's occlusion that occurs when the adaptive capacity of the periodontium has been reduced by previous bone loss or systemic effects of periodontal disease. Okay, so I like better the way I said it before. Something else that we need to understand. Examples of primary occlusal trauma. It could be acute or chronic. It could, the gingival fibers are not affected, but it could be placement of a high restoration, placement of prosthetic replacement, drifting movements, or excursion of teeth or orthodontic movements. Secondary trauma triggered by normal occlusal forces will increase injury or alteration upon exceeds adaptive capabilities of periodontium already affected by perio, not initiated by trauma from occlusion. In the presence of gingivitis inflammation. So then that will increase the attachment loss. All right. So we have this huge FMX showing us with huge bone loss all across. That would be secondary occlusal trauma. Something that we also need to know is people grind their teeth during sleep. It has been observed that bruxism can produce an almost uninterrupted, mainly horizontal load over periods of sleep and several times during the night. So bruxism is horizontal loads. In order to treat bruxism, occlusal adjustments can be made to improve the distribution of masticatory forces. We can also see some linea alba as evidence of bruxism, or also scalloped teeth marks on the tongue, or flattened weared out teeth on x-rays, especially in babies. the effects of occlusal forces. We know we're talking about it all the time. You got lateral, horizontal forces, and torque rotation forces are more likely to produce injury. If it's a continuous force, it's more injurious. If it's intermittent force, it's less injurious. Again, we must know the 3 stages of injury. Stage 1 is injury. Stage 2 is repair. Tissue response to increased occlusal forces. Okay, so 3 stages of tissue response to increased occlusal. Stage 1, which is injury. So these are not stages of injury. This is stages of tissue response to occlusal forces. Of tissue response to occlusal forces. There we go. Stage 1 is injury. Stage 2 is repair. Stage 3 is adaptive remodeling of the periodontium. Again, stage 1 is injury produced by increased forces, affects chronic, the affecting force is chronic. All right, stage 3 is repair. Increased resorption and bone loss. With excessive, the body will attempt to reinforce the thinned bony trabecular with new bone. Repair occurs as long as reparative capacity exceeds traumatic forces. And then stage 3 is if repair process cannot keep pace with the destruction. Okay, and that is like remodel. Okay, and that's bad. Insufficient, so that's too much, right? When you got too much thick PDLs, funnel shaped crest, when you have insufficient occlusal forces, which is the opposite, that's thinning of the PDLs, atrophy of the osteoporosis in alveolar bone, and reduction in bone weight. So if you're not using your mouth, you could get osteoporosis in your bones in the mouth. Wow. Which is a maxillary mandible. Wow. Okay, fremitus, you place a wet index finger on the labial surface of maxillary anterior teeth, activate to continuous bite-in-centric relation or maximum interconspiration. Vibration felt on the finger due to prematurity suggests positive test. So fremitus is not good. You don't want to feel vibrations when you have your finger on their teeth and they're biting. And centric, bite-in-centric relation position or maximum interconspiration. Remember, centric relation is when the superior posterior condyle and the mandibular fossa. Centric occlusion is when everything is touching. Okay, bottom line, we need good oral hygiene. All right, and make sure that malocclusion is of no periodontal. Malocclusion is of no periodontal significance as long as there is good oral hygiene. Only malocclusion becomes a factor to consider in the progression of periodontal disease. All right, so that was occlusal trauma. Let's go into TMD screening. So he asked this before. Give me some symptoms of some temporomandibular disorders. And there's multiple. You can have hissing, ringing in the ear, decreased hearing. You have popping, clicking of the jaw. You can have clenching teeth. You can have discomfort in the mouth. You can have limited mouth openings. You can have swallowing difficulties. You can have neck problems, neck pain, lack of mobility. You can have headaches. You can have head pain, like on the temples. You can have sinus pain, shooting pain up the back of the neck, vertigo. You can have, bloodshot eyes. You can have pain behind the eyes. You can be sensitive to sunlight. Your mouth can lock shut or it can lock open. You can't bite. You're grinding at night. There's looseness and soreness of back teeth. All those things are generalized symptoms for temporomandibular joint disorders. Pain, tenderness in the face, all that stuff. And also, so then we're going to have to, what are questions we need to ask patients to find out if they have TMD? All right. So he's going to ask us to give us 3 questions. I remember that because of the test. So here we go. You can say, have you noticed any grating or clicking or cracking when you open your jaw? Do you have sensations of stuffiness, pressure, or blockage in your ears? Do you ever feel dizzy or faint? Have you noticed if there are imprints of your teeth on the side of your tongue or on the side of your cheeks? Have you noticed if your tongue goes in between your front teeth when you swallow? Interesting. That could be an OMT question. Do you feel pain or soreness in any of the areas such as your jaw joints, your lower teeth, the back of the head? Do you have difficulty chewing your food? Do you have any missing back teeth? Have you had any whiplash? Do you have headaches? So all these questions are things we can find out to see if they have TMD symptoms. Is it painful to stick your little finger into your ears when your mouth is open, wide, and then close your mouth while pressing forward with those fingers? Wow. Okay, interesting. Is it painful or is there soreness when you press on your jaw joints, especially on the masseter area? Okay, good questions there. Again, a normal opening is a minimum of 4 millimeters, 40 millimeters. All right. When we're talking about intercisal distance. Assessment intercuspal position. Normal is centric occlusion. Centric occlusion is maximum intercuspation. Okay. It's normal. Okay. We use shim stock strips to check. Intercuspal position or centric occlusion is maximum intercuspation. Again, that's when we check for open bites, anterior, posterior, or cross bites. We can check protrusive or lateral movements. Protrusive is horizontal distance between mandibular incisors and maxillary incisors when the mandibular incisors pass beyond the maxillary ones. Okay, we know that. Okay, here we go to measurement of lateral movements, and we're going to be using the midline for this. You're going to have them in centric occlusion, and then you're going to have them to move from one movement to the left or to the right, and then you're going to measure as far as they go, and you're going to see what is this the millimeters or centimeters from midline of the maxillary to midline of the mandibular. Palpation of the temporalis masseters, and the muscles can help us determine. Joint palpation of the condyle. We have lateral poles and medial poles around the condyle lateral pole. Using one finger, we can palpate that. We need to know what deflection versus deviation. All right. Deviation is a shift in the midline during opening and returns back to midline. That's deviation. Deflection is a shift in the middle that becomes greater as the patient opens. So most people, I believe, have deviation. It's like you open and then it moves and then it comes back to the middle. Deflection is just corner to corner. It's corner to corner. Yeah, deflection is corner to corner. Yeah, it just gets greater as patient opens. The midline distance. Okay. Normal joint function is smooth, no pain. All right. Again, tooth mobility and wear. We need to know primary is normal periodontium heriforcis. Secondary trauma is normal forces periodontium affected by periodontal disease. Again, mobility plus is barely discernible. One mobility is combined facial lingual movements of 1 millimeter. Mobility 2 is combined facial lingual movements of 2 millimeters. And mobility 3 is facial lingual movements of 3 millimeters. So plus, barely moving, 1 mobility, 1 millimeter facial lingual, 2 mobility, 2 millimeters facial lingual, and 3 mobility is 3 millimeters facial lingual. And is also depressible for class 3 mobilities. Fremitus, again, it is the buccal aspect or facial aspect of maxillary molars. You have to put your finger on there and functional use for vibration being transmitted to the tooth. We know what attrition is. We know that parafunctional activities are bruxism. We're almost done with this one, but radiographic evaluations, excessive forces can be radiographically assessed. So widening of the periodontal ligaments, resorption of bony support, increased density of surrounding bone, osteosclerosis, increased cementum, hypercementosis. All that is things that can attribute to excessive forces in x-rays. Muscles of massification, myofascial pain, so tinnitus, ringing in the ears, fatigue when chewing, signs. So we talked about all this already. It's just like another review here. Subluxation or dislocation is when you got lockjaw, and you can sometimes help the patient pushing down and back, or not. Maybe I'm not. Can't think about that right now. So if people are clicking and the pain continues, they can get what's called discoplasty. Analgesic, soft diet can help them, but if it's relieved by that, they can continue with the Vitaplans. If it's locking and the pain continues, they can still get discoplasty or discectomy. But if it's relieved by Vitaplans, they can just continue on. So that was that. I believe we're pretty much done. It's because we're gonna go to the last one now. This is about dentinal hypersensitivity. There's 50 fucking slides on this. Let's go through it very quickly. According to Darby and Walsh, 30% cementum enamel meet without. Okay, we don't know. Biology of hypersensitivity. Hypersensitivity at the micro. So dentin contains large numbers. Dentin has dentinal tubules. We can see it. It almost looks like a honeycomb through a microscope. Contains dentinal fluid, which is disturbed and past ripples of stimuli of nerve endings, which is why we feel things, and it goes straight to the pulp. A delta fibers are myelinated fibers. Sensation of well-localized sharp pain. A beta fibers are similar to A, but they respond to electric stimulation. And then C fiber is dull, poorly localized aching pain. Okay, so A delta, sharp pain. B delta, only electric stimulation. So A delta, A beta, and C fiber. A delta, sharp pain, myelinated fiber. A beta, similar to A delta, responsive sensitivity, electric stimulation, and C fiber, dull, poorly localized. There's a lot of reasons for hypersensitivity. Periodontal patients, presence of women may be affected more than men. There could be predisposing factors such as dentin exposure, occlusal trauma, aggressive scaling, gaps or cavities, fractured teeth, defective restorations, all that. There's the hydrodynamic theory, there's the ionic change theory, and there is the evaporation theory. The hydrodynamic theory is the most accepted theory. Even though it's still under research, it shows changes in the flow of fluid present in the dentinal tubules can trigger receptors present on nerves and at the pulpal aspect, thereby eliciting a pain response. Increased changes in temperature, humidity, and air. So that kind of makes sense. We know what causes of enamel loss are: attrition, abrasion, erosion, abfraction. We know what dehiscence and fenestrations are, which is when the roots kind of like naturally start showing through the maxillary bone. Okay, we know what fractions and all that it is. Secondary dentin stimulation, obturation. All right, obturation is when something's being covered. That can be happening through calcium hydroxide, fluoride, silver nitrate, and all that stuff. So solutions and products that help with sensitivity are fluoride, potassium nitrates, oxalates, and calcium phosphates, fluoride varnishes, sealants, and arginine, phosphoric Do not put phosphoric acid on dentin, trigger sensitivity. But arginine is Colgate Pro Argin. Okay, combination of arginine and amino acid found in saliva mimics the natural process of plugging and sealing dentinal tubules. All right, takes 20 minutes of exposure to sugar for penetration. So that has nothing to do with arginine, but it takes 20 minutes of exposure for penetration through dentinal tubules. Okay, Sensodyne is potassium nitrate, desensitizes nerve ending, and it's and then Sensodyne also makes stannous fluoride, which is a physical barrier over dentinal surfaces covering dentinal tubules. We have products such as Gluma. Gluma is a glutaraldehyde hema formula, which seals dentinal tubules. So we need to know the process of application for Gluma. As part of a resin bonding with most bonding agents such as iBond, total etch, and self-etch. However, used under any indirect resin bonded inlay, onlay, or crown, could be used under amalgam fillings and under crowns cemented with zinc phosphate cements in conjunction with other dentin bonding systems, which may not provide a desensitization effect. So Gluma, there's two techniques that they use to place Gluma. The first technique is if the area is too sensitive to clean. No, the first technique is a tooth that is not that sensitive. You need to clean the cervical area with pumice, rinse with water, dry the surface with air. But if it's too much, use a cotton roll, and then once it's nice and dry, apply a small amount of Gluma with a cotton pellet or a microbrush using a gentle but firm mechanical pressure. Rubbing it will serve to assist with the delivery of the solution to all the affected area. Once you rub it on the affected area, you wait 30 to 60 seconds and dry and rinse thoroughly while applying suction. Patients shouldn't feel anything at that point. That's how you know it works. So once you apply the Gluma, you don't have to etch it, do anything. You just get a tooth that has dentinal tubules on it. Because you can't obviously do it on a filling or something like that. Once you find a tooth, you clean it, you dry it really well, then you apply with mechanical pressure, rubbing it, and then you wait 30 to 60 seconds. Then after the minute, you dry and rinse thoroughly while applying the suction. And then you repeat if the problem has been long-standing with the patient. So that's it. No light curing. That's it. Technique 2, if it's too sensitive with pumice, just dry it with a cotton roll and apply a small amount of Gluma, like we did in the first one. You still wait 30 to 60 seconds, but this time you're only going to dry, not rinse, if it's really sensitive. Apply a second coat of Gluma, wait 30 to 60 seconds again, and then on the second application, then you dry and rinse thoroughly. If the patient is no longer hypersensitive, apply Gluma to the desensitizer again using technique 1. All right, so technique 1, you pumice, air dry, apply it, wait 30, 60 seconds, and then air and water rinse. That's technique 1. Technique 2, because it's too sensitive, you don't pumice, you just dry with cotton roll and then apply it, rub it in, wait 30 seconds, dry it, apply a second one, wait 30 to 60 seconds, then you dry and rinse for that one. And then after that, you apply a third using the first technique. So technique 2 requires 3 applications. Servitech Plus is just another one of these things that prevents sensitivity. Yada, yada, yada. 5% varnish temporarily occludes dentinal tubules, but even though the material is lost in time, it's effective for hypersensitivity. Glass ionomers, adhesive lasers, other treatments, restorative. So, you know what? We got it. We talked about everything. He said, note this. All right, so look at this. Preventative recommendations for dentinal hypersensitivity. He said, put a note on this. Suggestions for professional. Avoid over instrumenting the root surface during scaling and root planing, particularly in the cervical area of the tooth. Avoid over polishing exposed dentin during stain removal. Avoid violating the biological width during restoration placement, and this may cause recession. Avoid burning the gingival tissues during in-office bleaching. Okay, so avoid over-instrumentation of root surfaces, especially in the cervical areas. Avoid over-polishing. Okay. So that's how we preventative recommendations for hypersensitivity. So don't over-polish. Don't violate the biological width. Don't over-instrumentate, especially on root surfaces, and don't burn the tissues with bleaching stuff. And that's where we ended it right there. Hopefully that all makes sense. And we'll listen to it again if we needed. Let's get an A in this class, motherfucker.